My name is Richard Duffy. I'm a consultant psychiatrist in the Rotunda Hospital. I work between the Rotunda and the Mater. So in the Mater, I do liaison psychiatry, which is kind of the interaction between medicine and psychiatry. And in the Rotunda, I do perinatal psychiatry. So I'll go on to explain what perinatal psychiatry is. So this is the Rotunda. We work pretty much in this shed. Now they've replaced and slightly upgraded the shed, but I'm pretty sure my office is exactly where that shed is. They've unfortunately done away with the tennis courts, which is a little bit disappointing. This thing is there still, but that's about all of the nice stuff that's there. But yeah, there's some amazing old photos of the Rotunda. So we got a nice new porta cabin as part of the new service, and porta cabins have come a long way. When I heard porta cabin, I pictured primary school and leaking roofs and that kind of odd smell. But we've got a very nice modern porta cabin, which is great. A few rooms to see people in, and a few offices. So it's really it's been great. So I want to run through a few things this evening. I want to talk about just the perinatal period, some of what it is, what we mean by it, some of the challenges that come up in it. I want to talk about specialist perinatal mental health care in Ireland, and then talk a little bit about what we do. So about before conception, during pregnancy, after pregnancy, breastfeeding, and then also just talk a little bit about some specific conditions, and then some of the general guidance and supports that we give. So as you can see, this is going to be a very rapid whistle-stop tour. So please, at the end, I'll try and answer any specific questions that are helpful. But these are the topics that I'll try and cover. So we'll start with the perinatal period. So what I mean when I say the perinatal period, so the antenatal period, so when somebody is pregnant, delivery, and then the postnatal period. So I'm including all them. And when we talk about people in the perinatal period, we will follow people after they deliver up until 1 year. So that's kind of where we cut off the postnatal period. In other countries, they're beginning to extend that out, and hopefully if they develop the services more, they will extend that out even further. In terms of, I think the antenatal period is really important, so before while someone's pregnant, because it's been kind of idealized. A lot of people have a perception that mood is generally pretty good and mental health stays pretty well in that period, and then people are much more familiar with the idea of postnatal depression. But in reality, the antenatal period can be just as difficult, and so I think it's really important to see that as an important part of it. So in Ireland, we have 64,000 births. I think this was 2016. And looking at the different conditions and their prevalence, we would estimate that about just over 2,000 people would need input from a specialist perinatal mental health service. This is a common condition. I suppose the other reason that I think it's really interesting is I have a close friend who she can describe very vividly. She's 35 now. She can describe very vividly her mother being depressed. My father is 60 and can say my mother was depressed. And so it's just so interesting how perinatal mental health conditions can stay with people and can stay with children many years after. So what are the conditions that occur in the perinatal period? Well, so these are the very severe ones where I think maybe psychiatry or the full multidisciplinary team become involved. And so in Ireland, taking 64,000 births, about 1 in 500 of those women who give birth will develop a postpartum psychosis or a puerperal psychosis. And this is a really severe mental health condition. This is a mental health emergency. People can get, and I'll go on to talk a bit about it more, but people can develop an acute psychosis over the matter of days just after they've delivered. They can have very bizarre beliefs, they can have hallucinations, and can just become very sick, can be very perplexed, confused. So it's a real emergency. Then you have people with chronic and serious mental illness, with schizophrenia, schizoaffective disorder, with maybe a severe psychotic depression, who have a baby, and often they do very well, but sometimes they need some level of additional support, and so sometimes they will be linked with the specialist perinatal mental health service. And then you have people who develop depression, and a cohort of them, about 3%, will develop a very severe depression that needs a lot of specialist input. So that's probably the most severe end who really need a lot of input. But there's a lot of other people who need other very significant amount of input. So again, about 3% will have an element of PTSD, and that may stem from previous traumatic experiences they've experienced, which the pregnancy and labour bring up and make more of an issue. Or for a lot of women, the process of labour itself can become very traumatic, and they can have a lot of trauma and symptoms of PTSD from that. 10 to 15% will have some moderate depressive illness or anxiety states, and 15 to 30% will have an adjustment disorder or will have other significant distress that has really impacted them. I suppose when we say adjustment disorder, what we mean is symptoms of depression and anxiety, but that are very related to the situation, and that when the situation resolves, often they resolve. But often individuals with adjustment disorder need levels of support, and so that's what our service tries to do. When we look at what are the different stressful factors that come up in the perinatal period, I've committed the great sin of all medical research here, and that I've taken research that was done on men, and I've applied it to women, which is what happens in medicine all the time and really shouldn't. But I did like the headings that it came up with. So this looked at Reddit feeds and what were the topics that new fathers were talking about. And they just came up with 4 groups that I liked, and that's the only really reason I've stolen it, which was there's individual factors. So there's a lot of factors relating to the individual. Some people are anxious individuals. Some people have a history of mental health problems. Some people have a history of trauma. And so for them, there's individual factors that make pregnancy or motherhood difficult or challenging. Then you have situational factors. And so sometimes just at the time there can be problems, and that may be health problems during the pregnancy. It may be incidental situational factors like occupational factors, partner factors. I remember being really disturbed to learn that rates of domestic violence increased during pregnancy, which I think is just a really disturbing statistic. And then there's a lot of factors relating to infant well-being. And so there's lots of different things that can be stressful as people progress through pregnancy. I suppose the other reason that there is specialist perinatal mental health teams is that often the decisions are quite complex. And so in psychiatry, we're always trying to weigh up what are the risks and what are the benefits of any treatment. And often we're talking about, well, what are the risks and benefits of, we take medication here, but any treatment, of stopping a medication or continuing or starting a medication. And so you're trying to think through this, which is kind of complex, and then you're adding in the baby as well as the mother, which has suddenly added a whole new layer of complexity. And then also, I suppose, with a baby, it's much more, it changes that balance of short-term, long-term. Maybe the mother's health is more important in that short-term. Maybe the baby's health is more important in the long-term. But often for different people, there's different considerations. And then you're thinking about that for taking medication beforehand, maybe taking medication during breastfeeding. So it can just be a lot of very complex decisions. And so I think it's really good to talk through those decisions with a team that are experiencing that. Some GPs are excellent at this. Many community mental health teams are excellent at this. But sometimes it's nice to meet with professionals that are doing this day in, day out. Also, I think it's really important to weigh up decisions carefully. I see a lot of people, and they are happy to take non-actions that have very potentially serious consequences, but are very afraid to take actions that might have low chance of a negative consequence. And so it's good to just talk through with somebody what that means. And so I see people who are terrified to take medication if there's a small risk, but are willing to assume quite a large risk of going with untreated anxiety or untreated depression. And so I think there just always is that bias. And it's not that I want to counteract that bias and say, no, you're wrong, you have to see it this way. But I want to give somebody a forum to just explore that in a bit of an open space. So what are the specialist perinatal mental health services? So just in the last 2 years, Ireland has rolled out specialist perinatal mental health service. In around 2017, this was published, the Specialist Perinatal Mental Health Service Model of Care for Ireland. And this is super progressive for Ireland. It's a very impressive document, because often we look at, and I think there was consideration when this was being developed, how do we treat the people with the most severe illness? But what always happens there is there's a cutoff. There's people who, well, you're not quite sick enough, so we're not going to see you. And what they did was they adopted a very comprehensive approach, and they looked at how do we actually help everyone? So even people with very mild illness, how can we support them? What about people who maybe don't even have an illness, but have a vulnerability towards it? Are there things that we can do? All the way up to people with, as we talked about before, postpartum psychosis. So what are the different things that we can do? So it's a very comprehensive model of care. It sets up with all the maternity centres in Ireland, it puts them all inside either a hub or a spoke. And so there are 6 hubs around Ireland. There's 3 in Dublin and 3 on the west coast, Cork, Limerick and Galway. And each of the hubs is connected to some spokes, except for Limerick, which just kind of does its own thing. But so there's a full multidisciplinary mental health, specialist perinatal mental health team in each of the hubs. And most of them are getting up and running. I think from Monday we will get a psychologist, which we poached from Pat's, so maybe I'll leave here quickly. And that will make us the first team in the country, I think, with a full multidisciplinary team. So I'm very excited about Monday. But the other teams are not far behind, and a lot of them are filling up their teams now. And so the hubs have the full multidisciplinary team, but the spokes have clinical nurse specialists or midwives who specialised in mental health, who will see women that are attending those spoke sites, and where necessary, they will link with the liaison psychiatrists that are in those regional hospitals. And if necessary, they will seek advice from the specialist perinatal mental health teams who are based in the hubs. So it's a pretty good service that's aiming to cover the whole country. Not all the services are fully rolled out just yet, but we're getting there, and so that's great to see. And so in the hubs, these are the teams that are there. So we have consultant psychiatrist, we have a non-consultant hospital doctor, we've specialist clinical nurse specialists who are mental health clinical nurse specialists. So these often work with where the specialist perinatal team are maybe liaising a lot with the community mental health team or with the GP. They have a really good understanding of mental health. A lot of them have come from working in community mental health teams, so they just link in with them very well. We have a psychologist. Occupational therapy hasn't been funded yet, but I'm really looking forward to this hopefully being funded. I think this would be excellent for just supporting people in coming to terms with parenting, how this works, and yeah, I think there's just huge potential for occupational therapy. We have a social worker, and I will come back to this and emphasise this again, but the work our social worker does is not TUSLA, is not kind of calling into question anyone's ability to parent. It's very much a supportive piece of work. I see a lot of people who come in really terrified that that's pretty much all we do, and it really isn't. So a mental health social worker who's really great expertise. We have an administrator, which has been a game changer for our team, which is brilliant. And then we have the teams of mental health support midwives. So the mental health support midwives trained as midwives, but a lot of them have then done additional training in mental health. In a lot of the sites, they deal with some of the milder cases, but often as well for the more severe and moderate cases, they have expertise where there is a lot of overlap between obstetrics and the specialist perinatal team. So where there has been a very traumatic birth, actually a midwife can be excellent to speak to, because they can talk through a lot of the difficulties that have gone on during the labour, and they just maybe understand what both sides are saying, can help translate that. So specialist perinatal mental health teams, they will see people from booking up until 1 year. People can self-refer, and I think a lot of people have an experience in Ireland of trying to access mental health services and meeting lots of barriers, and they don't meet the threshold for a community mental health team. There's a 6-month waiting list for a community mental health team, and so they've removed a lot of the barriers. The fact that people can self-refer and people are seen very quickly, and I suppose it's very important when it's a very time-limited thing. Also, we work a lot with GPs and the existing community mental health teams. If somebody's seen their community mental health team for 10 years, we don't take over the person, but we work with them. And if they want a second opinion, they want some input, that's what we provide. And we probably have a little bit of a lower threshold than the community mental health team. So individuals who maybe are being managed by their GP very effectively and don't need a community mental health team, but when they get pregnant, their GP maybe gets a little bit nervous that the GP is maybe missing something. They're people who often attend our service. And I suppose that some of what we do does involve preventative measures. We see people often with a vulnerability towards a mental health difficulty before they've even developed one, and we try and see what we can do to ensure that their pregnancy and the start of their parenting goes well, and that their mental health doesn't impact that. Okay, so what about the services we offer? So before conception, we do offer some services. So these aren't self-referral. These your community mental health team or your GP would have to refer somebody in. But for individuals with a history of major mental illness, that might be a postpartum psychosis, bipolar affective disorder, especially type 1, schizophrenia, schizoaffective disorder, or major depression. These people could be referred in. And what we do at these meetings is we review medication and see if we can both optimize the medication and identify any medications that would probably be best to avoid during pregnancy. But as well as looking at medication, we'll look at steps to protect somebody's mental health. We'll identify supports and services that are there that people can engage with. And try and also identify, sometimes it can be really useful to sit down with a partner and try to identify what are the early warning signs that somebody might be becoming unwell again. So they're the main things that we offer from a preconception counselling point of view. I'd be interested when our psychologist starts to see, do we want to offer more preconception counselling for more kind of psychological and less medical things? And so for individuals who've had maybe an experience of trauma and are considering conceiving, would our psychologists do a preconception counselling? I don't know. And so I don't want to tell you that we're doing something that we're not, but it's an area that I'm interested to see will we expand into. Okay. And so then during pregnancy, there's a huge amount of stressors. Often during pregnancy, prior pregnancies can evoke a lot of anxiety, especially people who've had adverse outcomes in prior pregnancies. There can be a lot of uncertainty about your own health or about a baby's health. There can be uncertainty about the relationship, and even a lot of people struggle with there can be a change of role for a woman who's pregnant. So someone who's been working might decide that they're not going to return to work, or even just how they view themselves. That can change. It can evoke a lot of issues about how you were parented, or if somebody's lost a parent, it can evoke a lot of issues from that respect. And then some people will have tocophobia, which is a strong fear of pregnancy or a fear of delivering. Primary is where that is in somebody who hasn't gone through a labour yet, and secondary is in someone who has delivered a baby. These are interesting. Has anyone seen these graphs? No? Okay. So they're not as bad as YouTube for just losing a day of your life, but they're close. Okay, so these are Google Ngrams, and so you can put in any word, 2-word couplet, 3-word couplet, and you can see how common this has been over the last 200 years. And so it gives you each word as a percentage of all words published that year. So you can see, was your name popular over the last 200 years? You can do really interesting. So you can divide it up by other countries. You can see Freud's influence increase in all countries except in Germany in the 1930s and 40s, where it dips. So you can see some really interesting things in these. It's not exactly hard science, but it's interesting. So everyone's happy talking about postnatal depression now. Only since the mid-70s. People didn't really talk about it before then. People talked a little bit about the baby blues before then. Everyone's kind of talked about puerperal psychosis, about the same for a good period of time. But why I put this up here is because people are only just starting to talk about perinatal depression. People have been very familiar with postnatal depression. But when you look, Veronica O'Keefe in Trinity, Professor of Psychiatry in Tala, she did some research looking at rates, the incidence or the prevalence of depression in people who are pregnant, looking at it, comparing it to people in the postnatal period. And the rates were pretty much the same. And so we see a lot of people who are terrified that when they deliver, they're facing this huge additional risk. And I'm often telling them, you're in the middle of it now and you're actually doing okay. So there is, so antenatal depression is a big thing and we don't talk about it. And so we should really be shifting the language from postnatal depression to perinatal depression. Perinatal depression, the symptoms look very like symptoms of depression. And so you have your core symptoms, you have your reduced mood, your reduced interest in something, and reduced energy. And the energy can be difficult because as people progress through pregnancy, often their energy reduces anyway. The biological symptoms, which we commonly see in depression, so reduced appetite, reduced sleep, they're often very hard to gauge in pregnancy as well, because people's sleep is often affected by their pregnancy. A lot of people have prolonged morning sickness, and that can affect their appetite, or people that get a lot of reflux, and so that can also affect their appetite. So they can be hard symptoms to gauge. What's helpful, I suppose, is the cognitive symptoms. So feelings of guilt, hopelessness, worthlessness. Asking about these things can be very informative. And I think if they're there, they're signs that people have often developed a depressive disorder. I just want to emphasize here, and it's not that the other conditions I mentioned aren't, they all are, but this is a very treatable condition, and this can be done through talking-based interventions. It can be done through social-based interventions, and medication has a role, and lots of medications are safe even in the antenatal period. And in the postnatal period, lots of medications are safe to breastfeed on. We can talk a little bit more about that afterwards, maybe. Anxiety conditions can come up in pregnancy. Panic attacks can get worse. OCD can get worse. Often there's pre-existing conditions in people who have been maybe struggling a bit through with them and haven't decided to address them. Often decide to address them in the perinatal period. They decide, hold on, now's a good time to actually address this, or I don't want to carry this into to being a parent, so I want to address it. And so that's why it's a good time. It's actually really nice. I work with people who are really motivated to get well, which is good. Okay, so that was just a little bit about the before somebody delivers. After somebody delivers, there are lots of different stressful life events. I think this is probably my son's favorite. He then wakes up and does this. I'd like to develop this, the kind of back rub. If we could get this going, that would be good. But there's lots of stressful things. Sleep deprivation being a major one. But there can be lots of other things. People can have experienced a very traumatic birth. Breastfeeding can be really therapeutic for some people, but it can be incredibly stressful, and it can be a real source of guilt and shame for some people. There can be a lot of social isolation. People have a lot of views of what maternity leave will look like, and for a lot of people it then turns out not to look like that, and they end up feeling very socially isolated, staring at a baby, not quite sure what to do. And actually, to go back to the traumatic birth, I think what's really important to emphasize with that is it's very much somebody's perception of it, and we acknowledge that, because I sometimes see people who objectively on paper maybe haven't had the most traumatic birth, but they had certain expectations that their experience was very different from, and that they were quite traumatized by that. And then you see people who've had incredibly traumatic births but felt a little bit prepared for it, and they're doing okay. But often the women who've had very traumatic births make the ones who have objectively had less traumatic births reluctant to come forward, but for them it was actually really traumatizing. And so I think to emphasize that the trauma is really where there is that discrepancy between the expectation and the experience, rather than it being an objective measure. There can be huge amounts of social and cultural pressure to parent a certain way, to have your child sleeping a certain way, to breastfeed or not breastfeed. There's a huge amount of that, and then mother or baby can have health issues, and health issues for a baby can be hugely stressful, even if it's a relatively mild thing. To get up, get out of the house, get them to an appointment. At that appointment, they say, "Oh, they need an ECG. You got to go into Crumlin. You got to wait. You can be waiting 2 hours." There can just be a huge amount of time eaten up by that, and that can be really stressful. And then again, I'm emphasizing this again, but people who see us often have this fear that they're going to be reported to TUSLA, or that having a mental health difficulty and having a baby is some reason why this makes you a questionable parent, and it really, really doesn't. And I really want to emphasize that. And what I think is particularly sad on this level is that it's often the people who feel that they're being questioned for some other reason who are doubly afraid to approach us. And so maybe people who've had a mental health difficulty before, or people who have a disability. I heard a very moving story of people who, from two different people, one who was blind and one who was deaf, who people had they felt people were calling into question their ability to parent. Because of this, they felt very isolated, their mood dipped, but then they felt that going to mental health services would be a kind of secondary insult, and that any chance of them being an okay parent would be taken away, but if they did that. So they didn't seek help for their mental health difficulties. So I think it's just really important that people do seek help, and that this really isn't a large part of what we do. Where it is, it's a really barn door, any health professional, often families would be concerned when it is a factor. Okay, so in the antenatal period, then what comes up? So for the majority of women, for 50 to 85%, there will be a period of baby blues. This occurs in the first 10 days, lasts 48 hours, and should be self-limiting. And why I say question the diagnosis is occasionally I see women who come to our clinic who say, oh yeah, I had the baby blues in my last pregnancy, and I will say, tell me a bit about that. And they'll say, just for about the first 3 months, my mood was low, I needed a little bit of an antidepressant. And I suppose that just looks a little bit more like a postnatal depression. And it's not that I'm really keen to label it one or the other, but I'm keen that people are aware of vulnerabilities that they have, and sometimes by not minimizing it by saying it was baby blues and saying actually it might have been a depressive episode, then people can be aware of their vulnerabilities, and by being aware of that, then I think that they can do a lot to prevent a reoccurrence of a depressive episode. We've talked a bit about perinatal depression, so I've skipped over that and gone on to postpartum psychosis. These are Google Ngrams again, and so they clearly used to call it puerperal mania, and people really liked talking about puerperal mania. They talked a lot about it in the 1880s. But this is what I was saying at the start, that you have this postpartum or puerperal psychosis. And the term puerperal mania has been replaced with puerperal psychosis or postpartum psychosis. It affects 1 in every 500 women. Onset is usually in the first week, but it can occur any time up to the first 2 months. And unfortunately, most people with this require inpatient treatment. Now, most people with this do really well. There's a very interesting, the recent Louis Theroux documentary on perinatal mental health. Some of the women with it, some of the women in it have postpartum psychosis, and you see somebody who's really, really sick and do really, really well. But the onset can be very acute. You can get severe psychotic symptoms, delusions, hallucinations. There can be florid affective symptoms, so people's mood can be very high, people's mood can be very low, people can be very perplexed, confused. It can be very hard to reason with somebody having a puerperal psychosis. Perplexity and confusion may be actually the dominant symptoms, and because of this, it's really essential to rule out that there's not actually a medical condition happening. So somebody could have an infection following maybe in a C-section wound or something like that, and that could actually be causing a delirium. So it's really important to work out that that's not what's going on. And because of saying that it's a mental health condition and not a medical one, in the UK there's been a number of deaths related to this. And then I suppose a big part of our role is identifying people who are at risk of this, so that we can so that we can offer support and make plans in case this does happen. And the people that we really see at risk are people with a prior psychosis, people with a prior postpartum psychosis, type 1 bipolar affective disorder, or a family history. A prior postpartum psychosis, you're probably nearly looking at a 1 in 2 incidence of having it a second time. So it's really important that people are linked in. But what I've seen as well is people who've had quite mild psychoses. So someone maybe had a psychosis at 18 that was maybe a drug-induced psychosis, but then 10, 15 years later, when they go to have a child, they develop a postpartum psychosis. And so it's really good just to flag that at the booking visit, and often you'll be linked then with the specialist perinatal mental health team. Thought it's important to say something about breastfeeding, because that's a big part of a lot of the conversations that we have. There's a huge amount of pressure that can be put on women to breastfeed, and these are just two that I found without much looking online. So, his well-being depends on you, and breast milk is best for your baby. And just there can be a huge amount of pressure from culture, from media that are put on women to breastfeed, and it can be a huge source of shame, of guilt, of pressure. It can lead to a huge amount of insomnia. People are trying to breastfeed all night. It's keeping them awake. They're never getting more than 2 hours sleep, especially if you have a hungry baby. It can be really stressful. And I'll always come back to the idea that for a baby, a well mother is a lot more important than breast milk, and it really is. And I suppose my priority, and I'll be quite upfront with people about this. My priority is that the mother that I'm seeing is well. I see a lot of people in their priorities. My priority is I want to be off medication. My priority is I want to breastfeed, and I'm very happy for them to be priorities, but they have to be secondary to being well, especially in this period. That said, if a person's priority is their priority, I'm very happy to work with people for them to realise that. But I think the best priority to start with is that you're well. There are many medications that are safe to breastfeed on, and it's very possible to have conversations around that. And for some medications, so some medications, when a baby is born, they can have mild, usually self-limiting, usually mild self-limiting symptoms of withdrawal from some of the antidepressant or antipsychotic medications. And actually breastfeeding can reduce that level of withdrawal. So it can actually be a useful thing. It's good to consider preconception. So we can work out, does somebody intend to breastfeed? We can choose medication. We can make medication changes at a point where somebody is well. I think that's very helpful. And then it's good to just think about just ways of being flexible and other solutions. And so mixed feeding, sometimes pumping is helpful for some people. For some people, pumping is an additional stress with sterilizing and all other kind of problems. Breastfeeding, which we can be planning to do, but then a baby is born prematurely. It sometimes isn't possible to breastfeed in premature babies because their liver isn't as developed. But then there are banks of breast milk which can be used sometimes for premature babies. So there's options out there, and it's very much worth having the conversation around breastfeeding. Again, there's a huge amount to say on it, and I can come back to that if people have questions. There's a few conditions that I thought it was worth considering in isolation, and so I thought it was worth mentioning a bit about OCD. I see a lot of OCD. I see a lot of people who have been doing okay with OCD, and maybe during pregnancy it flares a little bit, and they decide they're going to do it. They're going to do something about it. And when I see them, I realize they've had really bad OCD for years, and they've never really seen anyone for it, never been on treatment for it, and it can be very upsetting. But also, intrusive thoughts happen everybody, and so that's why I put this slide up. So this slide is because a lot of people will develop intrusive thoughts and can often be quite disturbed by them. This is based on people who don't have OCD, and this is people who do have OCD, and all these people are in the postnatal period. And people having intrusive thoughts of suffocating the baby, sexual thoughts about the baby may get contaminated, SIDS, the baby might have an accident, intentionally harming the baby, losing the baby somewhere, illness. Every one of these thoughts, people without OCD have at times. And so I just to say that obsessional thoughts can be a very normal thing to have. I think the best way it was ever shown to me in a room of people was someone said, write down, I hope, and then somebody you care about. Just write that on a page. So everyone wrote that on a page and then say, great, now write, dies horribly tonight underneath it. And everyone's like, no, I'm not writing that. So no one wrote it. And the person's point was, it's because all of us on some level think our thoughts have a little bit more power than they do. And on some level, that's what OCD is. It's that thought that our thoughts really are quite more powerful than they are. I thought it was an interesting demonstration that all of us have that thought a little bit. So OCD is really worth addressing, and we see a lot of it in pregnancy. Eating disorders, they can be very challenging during a pregnancy. What we often find is, so this is a study by Eastern, and what it highlights is that I suppose for a lot of people, the symptoms of eating disorders can get quite bad in the first trimester. They often settle in the second and third trimester. I think once somebody is clearly, obviously pregnant to everyone else, their anxiety about weight gain reduces, but often people who have been in remission can have a relapse after they deliver. And so it's worth somebody flagging it if they've had an eating disorder in the past. And then this is tocophobia, so this is the fear of childbirth, and it can lead women to avoiding pregnancy, women seeking terminations, late booking, requesting a C-section. And now with the specialist perinatal mental health teams, I think we can work with people who have a lot of anxiety and see what we can do to try and reduce that anxiety. It's actually more common in women who haven't experienced childbirth, but for women who've had a very traumatic past, maybe experienced sexual trauma, or women who have had a very traumatic labour in the past, they can develop a secondary tocophobia. And it's something that if it's identified early, it can be, there's things that we can do to reduce levels of anxiety. For people with a primary tocophobia, sometimes it's about bringing them up to the labour ward, showing them what happens in the labour ward, showing them the rooms that they're going to be in, and maybe some of the people that they might meet, and that can be helpful to reduce levels of anxiety. as I was saying, often we deal with kind of the milder end of things, or things before there is a major problem has developed. And so a lot of the advice that we give is quite general. And so I might just run through some of that that we do. I push mindfulness a lot. I think last month there was a talk on mindfulness. So we talk a lot about mindfulness. And there's a lot of different helpful apps, websites for mindfulness. Beaumont Hospital have a very good website. It's a bunch of apps, and Mind the Bump in particular is related to pregnancy. And then a lot of people you meet, you say mindfulness and they go, yeah, I downloaded the apps. Or they go, yeah, I tried the breathing thing, it makes me feel more anxious. And so I'll come back with a lot of people and say, don't worry about the meditations, don't worry about the focusing on your breathing, the body scan. Any activity that brings your attention to here and now, that makes you kind of fully aware and present in the moment, that's helpful. Where you're not worrying about what happened last week, you're not worried about what's going to happen next week, but you're just in that moment. And so in the antenatal period, that can be walking, colouring books, Lego. I found someone who really found Lego really, really helpful. Knitting, yoga. But also in the postnatal period, I'll often recommend just while feeding or while out walking with the pram, just give a portion of that time to be really present in that moment, not to be thinking about, okay, what do I need to do next? Or, oh, I can't believe that went that way. Just to come into the moment and just be fully present there. So talk a lot about mindfulness. Talk a bit about journaling. And that is sometimes just about tracking symptoms. So for some people, they like free text, and it's like, yep, by all means, write pages, and that can be very useful. But for people who that's a bit alien to, just keep track of some symptoms. What are your key symptoms that are distressing for you? And can you just keep a track of them, maybe on a scale of 1 to 10? Are there things that you do that are helpful, that are kind of self-care? Can you just keep a track each week of, have you been doing those things, or how much have you been doing those things? Intentionally putting in protective activities. And so, maybe there's somebody that people see and saying, look, just commit to seeing them once a week, to touching base with them, ringing them once a week. And as I suppose everyone's familiar with, when people become depressed, it can be really hard to recognize the positive things that you've done. And when you've had a week of being frantic and trying to care for a baby that's pulling you in every direction, to kind of be able to step back and recognize some positive things that you took from that week is really important. And then often just checking in with yourself. And I often get people to do this. I both the psychotherapist I saw gave me this as an exercise, and I did a coaching course, and we use this as an exercise. But it's just to spend some time following your emotions a bit, where when you maybe have some kind of core emotions, just to try and put a more specific word on it. And it can be a helpful exercise in just checking in with yourself and really just identifying, why did I feel that emotion? It then just gives you a bit of a sense of control over your emotions. If anyone wants to look at that, you just Google emotion wheel, and you'll get a copy of that or something like it. There's a lot of general resources that we give people. We, of course, give people the Aware website. But now that I'm aware of the online course, I'm going to start plugging that to people. Pieta House for people with self-harm. I often give people that. Because I work on the north side, the two low-cost counselling services that I recommend on the north side Counselling and the DCU Healthy Living Centre. Samaritans, occasionally I'll give people as part of a kind of comprehensive care plan. For younger people, I find Jigsaw to be a really good resource. Then there are some counselling services. There's a very useful website for emotional regulation. Something about pregnancy can be emotionally dysregulating for some people. People who don't have emotionally unstable personality disorder, but something about questioning, how was I parented? What does it mean to parent somebody? And then there's hormonal changes, which may increase a level of lability of mood. Mean that just emotional regulation can be that little bit more difficult. And so this is a website just around emotional regulation, and it's dvtselfhelp.com, and so I recommend that. And there's a few that are tailored specifically towards pregnancy. And so around pregnancy loss, there's pregnancyandinfantloss.ie. Postpartum psychosis, there's APP Network. Dads sometimes, there's the dadpad.co.uk. OCD, eating disorders, and then parenting. The HSE has some information on parenting. So then I suppose that was just like a brief run through as is possible. So just maybe a few take homes. Mental health difficulties are not a reason not to have children. And still, every now and then, you see somebody who has that view, or even if they don't overtly have that view, they feel, oh, I need to wait until everything's perfectly settled. And so I just really want to emphasize that it's not a reason not to have children or to not think about that. Specialist perinatal mental health services are now available nationwide, which is really good. And then looking after your mental health is caring for your baby. And so I really just want to emphasize people to prioritize themselves. And this happens not just in perinatal mental health. I see people who are caring for their mother and they're not looking after themselves at all, and their mood is going down and down and down. And so I just really want to emphasize caring for yourself is really important. Don't ignore problems. Look for help early, and especially with the perinatal mental health services, we're there to offer early supports. And then I suppose I just put in, be kind to yourself. I think around pregnancy and motherhood, people carry a lot of shoulds. I should feel this way. I should do this. They beat themselves up a lot about different things. And so I'm just kind of wanting to emphasize that people maybe, if they want a should, I'll give them a should. You should be kind to yourself. That would be helpful. Yes, and because parenting is super challenging. And yes, you at first you don't have a clue what you're doing, and then it stays that way. So just a big thank you to Aware, a thank you to St. Patrick's, to the perinatal mental health team in the Rotunda. Margot Wrigley and Fiona Reardon have done a huge amount of work developing the perinatal mental health service, so I think it's worth acknowledging them and just the other perinatal mental health teams around the country. There's some really fantastic public voices who've spoken out about this. I know there's a podcast that the RCSI and the Rotunda does where some people have spoken about this. And then on the Rotunda episode, the Rotunda TV series, 2 women spoke about their experience of mental health, and I just thought they were incredibly brave and really, really inspirational. The community mental health teams do a huge amount of work, and voluntary organisations do a huge amount of work in this area, and so I'm just very grateful to them as well. So I think that's everything. So yeah, thanks very much.